Good morning, and thank you very much for the kind invitation to be here. Roberto called me and he said that he gave me this sort of title, do we need an imaging cardiologist or do we need a clinical cardiologist who uses imaging? Well, my background is that I'm in clinical cardiology, and I think imaging we have built in the place where I work in Leiden in the Netherlands into something where we have the possibilities to basically visualize everything in the heart and the vessels, but the idea is that you apply it where you really need it. So I believe that imaging should be driven by clinical questions, and the clinical questions should then be translated in information needed, and the information needed you get from a certain imaging procedure. For this purpose, I've approached it slightly different. So I think in imaging we have at the moment various techniques. We have echocardiography, which is the technique that we use most often. We have MRI, which is a technique that we would like to use more often because it provides us such high resolution images. We have nuclear imaging with PET and SPECT, where we can very nicely assess functional consequences of, for example, a coronary stenosis. Is there ischemia or not? And we have CT. And CT has been moved into the field of cardiology very fast recently, because since a couple of years we are able to use a CT scan to non-invasively see the coronary arteries and the coronary artery stenosis. So basically we can do an angiogram non-invasively. What I will do in the next 30 minutes or so is I will highlight to you where I believe that these modern imaging technologies will be used mostly in the future. And you will see that it's quite clinically oriented. So if we speak about echocardiography, echocardiography has moved over the recent years completely in the direction of three-dimensional imaging. That was very cumbersome, very difficult to assess and to post-process. But nowadays, with the new technology, that can be easily done. And so we use it mostly for looking at LV function. This morning in the talk from Roberto Ferrari came already up that ejection fraction is an important parameter for us. We like to assess the cardiac function, so we use LV function. But what is also increasingly important is the assessment of heart valves. And why do we assess and why do we need more information on these heart valves? Because the therapies are changing. We used to have surgical therapy, and it's still there. You have a mitral regurgitation or an aortic stenosis. These are the two most frequent heart valve diseases that there are, both degenerative. But these diseases can now also be approached percutaneously. That means that we can repair or replace the valve percutaneously. And with that, the demands on the knowledge of the valve and the system of the heart vessels is becoming different. And that is where I think 3D imaging will come in. We can also use 3D echocardiography, but also 2D echocardiography, to have a better improved function assessment. We can move away from just ejection fraction, but we can look at the strain. The strain of the myocardium is the active deformation. How does the heart really function? Because if you measure an ejection fraction, it's basically no difference than just the volume what is in and the percentage of volume that goes out. Now let us assume that you have a severe mitral regurgitation. Half of the blood will go in the left atrium and half of the blood will go in the aorta. So the ejection fraction is not really reflecting what the heart is performing, because we always believe ejection fraction as the amount of forward pushed out blood. So I think that in the future we will start to see that strain, active deformation, the real function of the muscle of the heart, is becoming more often used if we speak about how good or how bad is the function of this specific heart. And then I will speak a few words about rotation and twist, which is more experimental at the moment. I will not give you so much data, I will just give you the images as we have them. This is something, you see that this image goes from 2008. That's when we just started by doing these approaches. When, for example, Matteo Bertini was with us, who is now working in Ferrara. So this is the approach that you can use with echocardiography. We have now probes what is the pointer here? And this one is the pointer? Yeah, I think it should be here. Well, if you see on the, is this the pointer? Ah, thanks very much. If you see here on this side, here, if you see here on this side, this is the probes that we nowadays use, and you will get simultaneously with one image assessment different views of the ventricle. And with these different views of the ventricle, the system can post-process very rapidly this sort of image. And this is a three-dimensional representation of the left ventricle. And from that, we can very easily assess ejection fraction. And very reliable also. And what you see here is that we first inject intravenously contrast, so that fills the ventricle, and then the border detection, the edge between the border of the myocardium and the blood, becomes much clearer. And from that, the software automatically calculates this. So 3D echocardiography will bring us much preciser assessment of ejection fraction. What we can do on the left ventricle, we can also do on the left atrium. And here you see this 3D assessment of the left atrium. Now, this is something we do not use in the daily practice, but it is feasible to do that. So, for example, if you speak about severe diastolic function, the question of how is the left atrium functioning is coming quite often. And from that, we can measure precisely the left atrial volumes, but also the left atrial function. The valves, as I indicated to you in the era that we are entering of percutaneous valve therapy, are becoming more important. And we have this transesophageal approach. You know, you do the transesophageal standard echocardiogram. But from that, we can immediately post-process all the different views of this mitral valve. This here is the left ventricle. This here is the left atrium. In between here is the mitral valve. This is the aortic valve and the aorta there. And you see that there is a problem with this mitral valve, namely there is a prolapse of this leaflet that's going all the way up. And we post-process that we acquire that in different views. Here you see the short axis view where you look on top of it. And then we can post-process that in these sort of images. And if I show you the next one, it is very easy to visualize where the problem of the valve is. And this is what the operators nowadays need to do the percutaneous therapy, either surgically or percutaneously. We also start to move in the direction of quantifying the exact regurgitant volumes with three-dimensional approaches. And quite often, there is not one jet, there is not one area where the valve is leaking, but there are multiple areas, as you see here in this mitral valve. And that we can also see much, much better. So we're shifting away in echocardiography from 2D to 3D, both for anatomical imaging, what I showed you in the previous, and functional imaging in terms of regurgitant volumes. And then we can quantify things from that, and we can measure, in this case in the mitral valve, the precise area of the mitral annulus, how much the mitral valve is retracted. We can split it into the anterior leaflet and into the posterior leaflet. This is more academical approaches. But the previous ones we use all the time in the daily practice. What we can do on the mitral valve, we also do on the aortic valve. And here you see again transesophageal echocardiography, where you visualize the aortic valve here. And you can visualize it in that direction where the ventricle is here, the mitral valve again is here, and the aortic valve is here with the aorta. And we can post-process that here in these 3D images. And we can differentiate between leaflets or cusps that are prolapsing and leaflets that are retracted. And you may say, is that important? Yes, that is important. Because if the cusp is no longer closing and you have an aortic regurgitation and it is due to a prolapse, you can do surgery and repair it. But if it is due to fibrosis, it's just retracted, there's not enough tissue anymore. And in that case, you need to replace the valve. So the 3D echo is not going only in the mitral valve, but also in the aortic valve. And the same applies here, that we can much better visualize and quantify aortic regurgitations, as you see here. So 3D echo is bringing us much more anatomical information and functional information. If we speak about this function assessment, as I indicated to you already, we believe that ejection fraction is a nice measurement and it works quite well if there are no valve problems. But if there is a problem with the valve, then the in and out volume equation doesn't work anymore. And in that case, we like to use strain. And strain is the amount of myocardial deformation. How much of the muscle is actually contributing to the function. And we can assess that in different directions. We can assess it in the longitudinal direction, sort of the up and down movement of the heart. And we can assess it in the radial direction, which is the inwards motion of the heart. And we can assess it in the rotational direction. So 3 dimensions of strain. And this is how longitudinal strain works, and this is very easy applicable. Most of the softwares of the normal echo machines nowadays have that. And you see here the longitudinal strain of this left ventricle. This is transthoracic echocardiography, left ventricle here, right ventricle there. This is the mitral valve, this is the tricuspid valve. And all these different areas, regions of the left ventricle are sort of color-coded. And what is derived from that? The software derives from you per segment the amount of strain. And what you see here is the peak strain in the different segments, and the colors correlate to the areas over here. I believe that it's probably better to look not just at a region in the heart, but at the global function of the heart. And what we can do, very similar, we take, again, the 3-dimensional probe, and we acquire in one image assessment the 4-chamber, the 2-chamber, and the 3-chamber views. You see that here. And we plot that in a global strain map of the heart. And a normal strain map of a normal heart is around -20. The minus you should not look at, just at the amount, 20. 20 means that you have a normal strain in a normal heart. And we can calculate that as I indicated here. This here indicates -20 for this normal heart. Now, put it in perspective for you. Here you see normal controls. Here you see patients with infarction. Here you see patients with heart failure. Here is that normal control. He has a strain of 19. And you see that once there is an infarction, the strain of the infarcted area is gone. It's no longer contributing to the function of that left ventricle. And it's very easy with this color coding to immediately pick up that here are very, very low strain values. So if we go from normal to an infarct, we see a loss of strain, and usually that's in the area of around 13 that you keep in the heart. And if you then develop severe heart failure, then the strain goes further down and it's reduced in every area of the myocardium. And the global strain is 7. So these values, 20 normal, 13 an infarct, 7 for heart failure, are the ones that you're going to see in the future. If we want to do risk stratification, this will sooner or later replace ejection fraction. And the question, of course, is ejection fraction the same as strain? And you see that there is a good relation between the strain and the ejection fraction, but it is not perfect. And the differences are specifically in those patients that have severe valve problems. That is where the ejection fraction and the strain do no longer parallel. You can use that. This here is 650 patients with primary PCI. They all have an acute infarction. The echo was done clinically 48 hours after the infarction, and the global strain of that heart was taken. Here you see 2 examples. This is one with an anterior infarct, which is most prominent at the apex. Here you see one with an inferior posterior infarct, very clearly visible. And if you look at the results, and we look at predictors of long-term mortality in this cohort, you see that the number of stenosed vessels was important, the troponin level of the infarct was important, the filling pressures are borderline important, but the strain and the strain rate is the time that takes the strain, these 2 are highly significant in predicting the outcome. And if you put that in a model, you see that ejection fraction does no longer predict. And this is clinically applicable, and I believe that sooner or later we will see this shift coming from ejection fraction to strain. Now then we have another thing, and this is a bit more academical, more research. We can also look at advanced LV mechanics derived from 2D speckle tracking. 2D speckle tracking is a new way of looking at echocardiography. I will not go into the details. But what we can do, we can look at basal rotation. The basal rotation of the heart is clockwise, and the apical rotation is counterclockwise. And these two that go in different directions, they give you the twist of the heart. And that happens in the subendocardium and in the subepicardium. And I'm just going to show you an example. Just look at these two slices of the normal heart. Here you see an apical part of the ventricle. So you take a short axis of the ventricle, and this is the apex. And here you see the basal. And from that we can assess the amount of torsion that's taking place in this heart. And if I show you now, up there, a severe heart failure patient, you see that this torsion is almost gone. There is no more this ringing motion of the ventricle. And the question for us is, what does that prognostically mean? Will that be a parameter that we use in the future? Let us now switch to MRI, magnetic resonance imaging. What are the strengths of MRI? Where do you use it in the clinics? Where do I think that this will fit in? Well, I think if the question is the best assessment of LV function and RV function, it will be MRI for the moment. But what is also important is the tissue characterization, and we come to that in a second. Let's first speak about function. Here you see different views from MRI. There is a two-chamber view with the ventricle here and the atrium there, the mitral valve in the middle. Here you see a four-chamber view with the ventricle here, the right ventricle there, right atrium and left atrium. And here you see a short axis view with the left ventricle and the right ventricle. And you see immediately that the resolution of this technique is much, much higher than echocardiography. And that also indicates that echocardiography is a good tool for looking at LV function as a global screener. But if you want to have the precise number, you need to switch to this technique. Then if you want to take a look in the future, this is actually the flow patterns that are happening in the ventricle. And the flow patterns are not the same in every disease. When you look at the heart failure, there's almost no flow. It's sort of a swirling motion. But if you look at a regional infarct, this flow pattern is disturbed. And when you look at diastolic function, the flow pattern is also different. So this is something we don't use routinely, but it's something what you will hear about in the future when you look at MRI and function. The right ventricular function is the most difficult for us to assess because the right ventricle sort of wrapped around the left ventricle, and dependent on filling pressures, depending on pulmonary pressures, depending on valve function. And the way to optimally assess it is really MRI. If you want to have the best RV function assessment at this moment, your question is pulmonary hypertension, what is my RV function? You do an MRI. Now let's switch to this, and we speak about tissue characterization in terms of infarction. We can look at scar tissue, but we can also look at edema. But what is also very interesting if we look at non-ischemic heart disease, and that is where MRI really provides something that none of the other imaging techniques at this moment can give us. And quite often we have in the heart failure clinics the question, this patient presenting with heart failure, the angiogram is normal, what is the reason? And then you want to know, is this a myocarditis? Is there amyloidosis? Is there some other disease? What's going on in that myocardium? And that is when you use MRI to look at tissue characterization. If we take a quick look at MRI in ischemic heart disease, this is what infarction looked like. Here you have again the right ventricle. Here you have the left ventricle, and the black is the normal myocardium. And the white is actually the infarcted myocardium, and you see here that this patient has a subendocardial. Just the inner part of the myocardium has been infarcted in the lateral wall. And in this patient, you have a subendocardial infarction of the anterior wall. It's not completely because there's also some black remaining. But you clearly see where is the infarcted tissue. This is a bit more difficult already to see, but this shows us where there is edema. And if you do an MRI very early after infarct, you see that this slightly denser area, that little bit opaque area, is where the edema is. And if you compare that area with the final infarct size, you see that there's a difference. Usually the edema is much bigger than the final infarct size. And the difference between the two gives you the information when you have done your intervention, your PCI, how much myocardium you kept alive by doing the intervention. This here is ischemic heart disease. Ischemic heart disease with MRI is easy to detect because it always comes from the subendocardium and spreads to the epicardium. Here you see again a non-transmural infarct, and here you see a transmural infarct. But if we speak about non-ischemic heart disease, we see sometimes patterns like this, which is in the middle of the wall, there is this fibrosis, or sometimes it's at specific places where the right ventricle inserts, and all of these correspond to different diseases. And I just give you two examples, if we look at that. Here you see a patient, and these are different transthoracic echo views, and you see immediately that this ventricular muscle is a little bit speckled, it's a little bit dense, it's thicker than normal. You see that there is a little bit of effusion here, and you see that the systolic function seems pretty okay. But the relaxation is like, tcha, tcha. It is not really relaxing. So this points for us, if you work in echocardiography, to the direction of amyloidosis. With MRI, here you see again that the systolic function is quite good, but the relaxation of the left ventricle is not completely normal as it looks visually. And if you now apply this delayed enhancement, this contrast, you see that there is complete endocardial scar formation. This can never be of an infarct, because then you would have an infarct in all three vessels. So this tissue characterization with the MRI really gives you a very good view on what is going on in the myocardium. Now I give you another one. This is a patient with myocarditis, and you see very clearly that the delayed enhancement, this white dense area, is not in the endocardium, it's also not in the epicardium, but it's in the midwall. This is very classical for myocarditis. I've shown you very good images, the best examples we have. If you see it, it is very specific. This is no doubt a myocarditis. But if you don't see it, it can sometimes still be a myocarditis. So the strength, very specific, but not that sensitive. We have spoke about echo, MRI, what are the strengths, and the last couple of slides are on the use of CT angiography. What we can nowadays do with CT is that we can quite easily visualize the different coronary arteries. The right coronary artery, the LAD, and the circumflex. And you see here that there is calcifications here, there is some obstruction here because the contrast is no longer complete, so there is some obstruction taking place there, and we can quite easily visualize that. How do you use this very nice tool, but difficult sometimes to interpret tool in the clinical situation? Well, what is perfect is the negative predictive value. That means if you see nothing on your CT scan, if there is no stenosis, no calcium, no atherosclerosis, this patient with chest pain is not a cardiac patient because he has no coronary artery disease. You could argue that he has some myocardial spasms or so, but it is not coronary artery disease. Is this useful? Yes, it is. Because if you work in the daily outpatient clinic, you often have patients with a relatively lower likelihood of coronary artery disease. You do the CT scan, you rule out immediately coronary artery disease, and the patient is discharged without coming back. Here you see one of these examples. You see that the vessels are completely normal, and you see that there's absolutely no stenosis. Here there is a little bit of intramural course. It is in the muscle, but there is absolutely no stenosis. If you want to work with this, you need to know, you need to have prognostic studies that tell you that if the CT scan is normal and I do discharge him, that his outcome is good. And this data is available. This is 14,000 patients with a follow-up of 22 months. And you see that the normal CT has a mortality rate of 0.65, all-cause mortality. So this looks good. When the CT is normal, you can assume there is no coronary artery disease, you discharge the patient, and the outcome will be good. But what if you see these images? And this is not so unlikely. You see there is calcium there, you see there's heavy calcium here, you see there's some stenosis maybe there, here is something going on. This is extensive 3-vessel disease. If you take a man, let's say 60-something years old, and he comes in with atypical complaints and you do the CT, this is not unusual that you see that. So now what? How do you deal with that? And then we have to remember that we like to know the functional consequences of the anatomy. If there is stenosis, does this stenosis cause ischemia? And that we assess with the nuclear scan. Here you see nuclear scans where you inject a radionuclide. You can do that with PET and or SPECT. And we see here that if the total myocardium is ischemic, if that exceeds around 10, actually it's 12.5%, the outcome with revascularization is better than with medical therapy. So this gives us the information that we need. If we see all this atherosclerosis and stenosis on a CT scan, we do a nuclear scan. If there is no ischemia or very little, we treat medically. And if there is a lot of ischemia, then we go to revascularization. How does the field in the near future look like? The industry is working in that direction to fuse, to integrate in one machine that you can do both CT and nuclear imaging right away. And this is an example of that. You can do a CT scan as a first step, and then immediately thereafter, you assess the perfusion here of the left ventricle. And then you can correlate a significant stenosis, or here, with an abnormality in perfusion in the myocardium. So you get this information in one, and it fuses directly for you what is where and what are the consequences. The thing is that you can do it stepwise. You do the CT scan very fast in a few minutes. If the CT is normal, nothing. But if the CT is abnormal, then you can follow directly with the fusion imaging of this nuclear technique. The last 2 slides that I have are on the CT alone. You can also do this on the CT scanner alone. You do a CT angiogram and you get this information that there is calcification, some stenosis. And then we can assess perfusion of the myocardium. And these are the first images that we have, and you see that here is relatively dark area, darker than the rest, and that indicates that the perfusion is not ideal there. But you also see that this is very much in development, because this is not something that you can say, oh, I see immediately that it's abnormal there. But the idea is that you can then present that in polar maps. Here you see the abnormal stress perfusion with the CT. This is the abnormal rest perfusion. So there is significant ischemia. And then you can do the same as with the PET and the CT. You fuse the perfusion and that coronary arteries, and you build the model where you integrate anatomy, stenosis, with functional consequences, ischemia. I've tried to cover this time from a different angle. I took the 4 big modalities that we have. I've given you what I think where the field is going. I think for echocardiography, valves, because there is a real demand for that in 3 dimensions. I've also shown you that the function is probably shifting from ejection fraction to these strain maps. And the strain maps are a reality. Every machine does that for you nowadays. I've shown you where the strength of MRI is. If you want to have the best assessment of LV and specifically RV function, you do an MRI. I've also shown you that if the question is what's going on in the muscle, what is the disease in the myocardium, like a myocarditis or an amyloidosis, you can do an MRI with contrast. And in the last part, I've shown you the CT angiography, which is more and more used in patients with chest pain. It's easy if the CT is negative. Prognosis is good, and you can use it clinically. But if the CT is positive, you need more information. You need to know how to treat that patient. And I've shown you that if there is a lot of ischemia, you need to revascularize. And if there's little ischemia, you do not have to revascularize, you do medical therapy. And the integration of anatomy with the CT scan and perfusion of the ventricle with a nuclear scan, or maybe in the future with the same CT scanner, gives us the complete picture on the basis of what we can treat the patient. Thank you very much.
Thank you, Professor Bax, for this very complete overview of the imaging in cardiology. I agree completely with you about the use of echo to move from ejection fraction to some other parameter. I think that now the 3D echo is very useful in interventional structural cardiology. We do mitral clip just on echo control. It is mainly directed by the cardiologist who does echo during all the procedure. Some year ago, I make the one provocation I suggested, and after some problems, some tribulation, I will talk about tribulation of trials, I been accepted by American Journal one paper about the use of CT scan in asymptomatic patients over 65 with more than 2 risk factors. And we found in this work, in this we did in my university, that 6 or 7%, I don't remember, of patients asymptomatic had left main disease are the patients who die suddenly. So maybe we can suggest, and the negative predictive value is very important, because one technique which has 100% of very negative, true negative value is a very important technique. What about the use in asymptomatic CT scan?
That is a very difficult question. And the work you have done is extremely important, because we need to gather information which individuals, because we're now talking about screening. This is no longer patient care, but this can switch easily into the direction of screening. I think what I've always learned is that for screening you have fundamental prerequisites. The disease needs to be prevalent. Our disease, coronary artery disease, very prevalent. You need to be able to detect it. We've shown with the CT scan that it's possible to detect it, and specifically the high risk, like left main and proximal LAD. You also need to be able to treat it. That is a little bit debatable, because left main, everybody agrees that we should probably treat. But if it spreads to a little bit mid-LAD, should we do something? Should we do not do anything? And so the consequences of the findings in some are very clear. Negative, you don't do anything and the patient is clean. Very positive, the patient is probably supposed to undergo something, and the middle group is where we will have problems to define specifically what we need to do. And the last thing, is this going to be cost effective? And that's of course what needs to be determined. But I fully agree with you that this technique sooner or later will translate into the direction of screening for coronary artery disease. I cannot say at this moment in time.
In high risk group, because we follow the patients, we have many, a lot of attention to preventive medicine, but still 60,000 people in Italy die suddenly for unexpected, sudden and unexpected. So that means that we are not able to identify patients who will die.
Well, that is exactly the point, eh? And the whole discussion, and that becomes even more relevant in this year, I did not go into that, but we are always thinking about stenosis, ischemia, infarction, death. But if you work in the cath lab, you get also sometimes confronted with very little lesions where there have been a rupture and immediately a complete occlusion and a big infarction. These are always the worst cases that you can prognostically think of. And so the information we need is not purely anatomical, stenosis, obstructivity, but we also need to learn and to understand better what is a vulnerable lesion. And there's a lot of research ongoing on vulnerability of a lesion, but that is far from realistic. So I think where we can use the screening is it's very obstructive, proximal left main, these are not good. But then what about all the other ones that do not have that, but will still event sooner or later a sudden death or an infarction? probably to some part related to a vulnerable lesion in the coronary system. That is very difficult, I think, and that is the part where the screening will be difficult to move forward. But I fully agree with you, the ones negative, excellent prognosis. The ones very positive, left main, we need to do something. So that discussion, I think, will take long, but sooner or later you will see that it switches into the practicality and people start using it.
Please, Professor Fabbri.
First, thank you so much for joining us and for delivering such a comprehensive and very interesting lecture. Two questions, one specific and one broader. The specific is in this week issue of the New England Journal of Medicine, there is a debate on the screening before sport. So the question is any useful information? And of course the screening is without or with cardio workout. The second question is, this is a cardiovascular and respiratory course. And we have plenty of evidence now that people with acute pulmonary event have cardiovascular and vice versa. So particularly the CT, PET, the last part of your presentation, do you think that, or are you aware of people that are looking at the broad spectrum, both vascular and myocardium in their screening? And do you see a perspective there in looking comprehensively at the thorax in both events?
Okay, so to come to your first question, the screening in sports is a very difficult one, because I once was at a congress and somebody presented from the United States a case of a young individual who was playing professional ice hockey. And they did some screening, and they saw on the echo that the muscle of the left ventricle was too thick. So then you have the issue, is that the hypertrophy disease, or is that a consequence of that this person is doing so much sports that his muscle has hypertrophied as a reaction to the action? And then eventually decided, okay, we will take him out of the sports for a year and we will look at what happens to this ventricle, to detrain him more or less. And they detrained him, and indeed the ventricle regressed. The only problem was that this guy's career was finished because he never came back to the level where he was. So this illustrates immediately again the problem of the screening, that we do not exactly know what we're looking for. And that, I think, is the difficult thing. So there are people moving forward with screening, with ECGs, with echocardiograms, but I think, and that is one of the things why I believe that imaging in itself is nice, but you need to look at it from a doctor's perspective. You need to ask yourself the question, what do I want to know? And if I know it, how do I treat it? What do I do with this information? And so for me, the discussion about screening for sports, on the one hand, it has a lot of good, because you could prevent potentially a lot of bad things. But at the same time, you could also do a lot of overdiagnosis and medicalizing individuals that are not. I don't have a good answer to that for you. That is my personal view on things. And if you speak about the global integrational assessment of heart and lungs, that's very, very close, because with the CT scan and also with the MRI scans, this becomes very possible that we measure all these things in one. And there are a lot of diseases where we don't know really what's happening. Is this pulmonary elevated pressures, and is that related to a heart disease, or is that a primary lung disease? If you look at mitral regurgitation, left atrial enlargement, atrial fibrillation, is that secondary to lung disease? Is it primary? So these sort of things, I foresee that there's going to be a lot of emphasis on that. But also the relation between simple coronary artery disease and lung disease seems to be present. So that is another thing that people will start to look in. And with these larger machines where we can visualize a lot, I'm sure that there will become a lot of cross-correlations, cross-correlational studies where you can assess all these things. Whether it will immediately translate into therapeutical consequences, that's difficult. But the hope I always have is that we better understand atrial fibrillation, mitral regurgitation, and lung disease, because that's a very difficult one for us to treat.
Another question from...
Thank you so much, really. As you know, somebody believes that echocardiography is not an imaging technique. It is simply a prolongation of the stethoscope. I think that is an important statement, of course. If this is correct, we probably should orient the training of our young fellows and should probably modify our way of being clinicians, making it possible to visit each patient necessarily with a sort of fast echocardiography. What do you believe? What you are forecasting for the future?
This is also a difficult issue. We did not speak about that, but you have nowadays these sort of echocardiographic stethoscopes. These are very little machines this big, like an pocket agenda or something, and it has a probe to it. And there are certain hospitals where they take this into the warding, the rounding on the wards, and they just do the echocardiogram immediately, and they don't use the stethoscope anymore. I think for the moment in time, I always propagate that we should at least understand how to use the stethoscope and to listen to the murmurs, because you can still learn a lot from it. But to be realistic, this will move into the clinics fast. And it is useful because you are in the emergency room and the patient is dyspneic and you take a quick look at the function and it looks normal, so it is probably not cardiac. So these sort of conclusions are being possible. So I share with you that this will shift into the clinics. The only thing we have to take very good care of is that you realize, and I just said it, the patient is dyspneic, the cardiac function is normal, so is not the cardiac. That's not correct. It could be also something more subtle or more something that we not always see. So one of the problems there is over fast conclusion, that you conclude too fast. And the other thing is that you also need to be trained quite well in echocardiography to really understand what you see. So I think still a fundamental training of echocardiography is needed before you start using these things. And then once you have done it, and most of the cardiologists are trained quite well in echocardiography, then you can start using these things in your outpatient clinic, in your wards. And then the third problem I see is the documentation of things. Because if you do an echocardiogram nowadays, it goes into a computer and it's digitized images. And when you want to get that back at some moment, you can get it. With these things, for the moment, there's not a real storage system, and so it's just look and go. So the answers to all these questions are quite difficult, and I don't have them, but I foresee that this is something we will not escape. This will happen. The only thing is that we need to take very good care that we work with it at a high quality.